Hello.
Good morning.
Good morning.
Happy Saturday.
Thank you. Same to you.
How was your Thanksgiving?
It was nice. How about yours?
It was good. It was good. Look, reading.
Good morning, Terry.
Good morning, Terry. Feel free to come up to the stage and introduce yourself. I need to let you know that the session is recorded, so just let you know that off top. Well, welcome.
Clarice, where's the link to the room?
It's in the let me send it to you. Let me send it to you. Normally, I thought I had the event scheduled. And then when I went out here on Clubhouse, there was no event scheduled, so I just opened up a room, but I'll send it to you.
Okay.
Or it's yeah, wait a minute, let me send it to you. What I want to do? No, I don't want to paint something in the room. No, no, no. Oops, I don't want to do that either. See, I'm doing stuff that I don't have no business doing. Open everybody in the room. Okay. I was trying to invite her to speak. There we go. You would think I hadn't done this all week, right? Or every week for the past several months, right? Here, I'm gonna bring you in this room. Copy. And let's see. Okay. Let's see. So you had a good Thanksgiving.
Yes.
All of that. Wonderful, wonderful. How's your work week? Did you have to, oh, you're still not there.
No,
I'm
not
jumping the
still.
gun.
I got a whole nother week.
I'm jumping the gun. So you just on vacation.
Yeah, look. Unfortunately.
Okay, let me see. Uh-oh. Okay, I'm gonna send it to you on the same thing that you sent the information to me on.
Okay.
And where are you? La la la. um, hmm. It's not showing up. Hold up. Where are we? What's going on? Oh, it might be in this folder. I know that information in that article was really helpful to me for various reasons. I said, "Oh, what if this is not um, propelling me in this direction? I don't know what is, Lord." What are you doing? What are you doing? Okay, where is it? I don't know. It's not showing up on my phone. Hold on. Did Terry join? No. Do you know Terry?
Yeah. Terry was doing last week.
Hey, lady.
She's at work. I think she's at work again. She's an X-ray technician.
Okay. Okay. Oh wait. Wait a minute. I might can email you this way. Hold on. Let's see if it let me do it this way. Okay, wait. Here. Okay. Are you on Chrome on your computer?
Yeah.
Okay, cool. That works. Fabulous. Let me send this link to you. Hold on. Okay. Let me know when you get it.
Yeah, I already clicked on it. And I'm getting okay. I know that. I got a minute.
Hey, I see you. Okay, wait a minute. Let me see. Add you to the stream. You got feedback from her.
Now I muted my.
Okay. It might be on my end. Maybe. Did you mute your StreamYard or turn your StreamYard down? If you can mute the StreamYard, then people in StreamYard can't hear you, huh? Let's see.
Can you hear me now?
I can. So whatever you did worked.
I turned down. I muted myself, but I also turned down the volume on my phone.
But you're not. Oh, you muted yourself on StreamYard. Okay. Or yeah, not StreamYard. On Oh, hey Terry, she came up. She did come up to the. How are you? Welcome. He said you're probably at work. All right, all right, all right, all right.
Good morning.
Good morning. How are you?
Good. I'm off today.
Oh, well, yay.
Okay, good.
That's what's up. That's what's up. Well, welcome to the Saturday morning tea.
So much.
So how's your studying, Terry?
Oh, it's coming along. I'm gonna do some today.
Okay.
So what are you studying for?
PCP
Okay.
A license.
Okay.
Yeah.
So you welcome to the wonderful world of medical coding.
It
Terry,
is challenging. It is not easy.
No, it's not. It's not for the
It's-
faint of heart either. We try to tell folks.
Terry, did you look up the information about the A?
yeah, I did.
Okay.
Yeah. Yeah, the sooner you can put any work experience or anything that you have related to coding and, try to get that A off.
Because Terry was saying that she sometimes has to verify the procedure codes before she does X-rays,
Oh,
and I said, "Well, that's your count."
there you go. That's right. However many years you've been doing that, add
That's
that
right.
to the information when you submit your application for the exam.
Yep.
Yes.
That's good to know. I didn't know that.
Yes. Oftentimes people don't understand or don't realize that they have had some sort of coding experience in the jobs that they have, and negate to put that on there. And so then you're stuck, because I don't think you can go back and change it once you submit your application. You're stuck with, well, you can use it, I guess.
You can, but it's just easier.
It's easier to do it up front. So
Right,
then
because
you only need 6 months or you only need a year or what have you.
because
But
that
if
way,
you
as soon as
submit
you pay,
longer than that, you use the entire time.
right, and then as soon as you pass, you get your CPC. You don't get an A, and have to worry about getting another certificate issued.
Correct. Yes, ma'am. And yes, sir. All right, sir. Well, again, welcome, Terry. Good luck with everything. And I see you got the coding nurse in your pocket. So I'm sure he'll help you along with anything you have. But if you have any questions, feel free to ask away as you're going through your study. So you can always check in with us, and we'll help as we see fit. I know he will drop some tea.
I try.
He will drop that tea in a heartbeat. So okay, so we're on here. We're here. So let's talk about this wonderful bit of information that you sent to me. Oh wow, I was loving it. I went to I went to a concert last night. Patti LaBelle was in town.
Okay.
And so I went to see Miss Patty. So while we were waiting for Miss Patty to come out, I'm highlighting my notes for I read everything that you said in that initial kind of summary, but then I went through the report like,
Yes.
oh,
Was that report not something?
I was like, yeah,
UPMC was firing some shots in that report. Were they not? They're like, we don't know. We disagree.
But the beauty of that is you do get the opportunity to do that. I know when I'm working in compliance, when they, request the records, and then you do have that back and forth where you can go, where you can say, well, whatever. But as usual, at the end of the day, your documentation is going to be what it is. Perfectly, your documentation is intact. And I was like, wow.
Because
go ahead.
now, what I want to, I want to know what your take is, because from what I read, it seems like UPMC's two main contentions were, number one, the audit company did not review the entire year's worth of records. And number two, they were saying that an RHIT did not have the skill set to audit those records.
Was she only an RHIT?
Pardon?
Was she only an RHIT?
That's what UPMC was saying. They were saying that the minimum that someone should have was a CRC, not just an RHIT. I don't know if I agree with that.
I don't agree with that at all.
But I was like, well, why would they not review the entire year's worth of records? Because that's what you do when you do auditing for risk adjustment. Anyway, you do the whole year. So they were saying that they didn't
pulled out accounts, certain accounts. No.
Well, that's how it works. You get they pull a random sample.
Correct. But you look at the year from that random sample, because you need to justify that there hadn't been a visit or had been a visit. You need to, let me flip that. You need to validate that there had been a visit during that year that is the diagnosis that you put on that claim. I'm with you on that one. I believe with a person with an RHIT, just because they don't necessarily have the certification doesn't mean that they're not qualified to do that. You're taught under the AHIMA domains, you're taught everything health information. That person can take it upon themselves to specialize in a certain area, such as coding or HCC or what have you, and can potentially be self-taught without the certification. But yeah, I mean, I guess if they wanted to say, and I don't know what the government's criteria is for their subcontractors or what have you. I mean, maybe that will be something that they would consider going forward, is to make sure or validate, I don't know if they want to change that.
I worked for one, I know was one company that was a government subcontractor. And for them, you had to have your CRC in addition to whatever else, but that was the requirement.
Okay. But clearly, I guess it varies from company to company. But maybe they've used this person, or maybe they've used the auditor and other things and hadn't had a problem. I don't know. But at the end of the day, they still got money to pay. So.
I'm like, if that's your best argument, I
know. don't you're like, don't come for me.
Right.
Yeah, that's a little thing, because your documentation, however, if there's nothing that you can find to justify that, then what does it matter? It doesn't make sense.
Exactly. So because to say that people didn't review a whole year's worth of records, or didn't review all the records that were sent, like that, because the report was very clear on what they didn't capture or what wasn't supposed to be captured.
It was very clear.
But what their response wasn't, they didn't have not a shred of evidence other than to try to come for somebody's credential, which is really not even relevant.
Right. You're right about that.
But I guess when you're faced with a $6 million bill, you do those type of things.
You're grasping for it all. Like, I want everybody to look at everything.
Yeah.
Please, ma'am and sir. Yeah, and I found it seems like for the majority of the cases, there were just histories, and there is nothing to justify. There wasn't enough documentation to justify any acute. Is that something that a lot of folks find when doing HCC reviews? Or
I'm going to tell you the problem. The problem is
here's the T. I need to have a here's the T button.
It all comes down to training.
Okay.
Because everybody, when you do risk adjustment, there is not a whole list, but there is a list of chronic conditions that you can abstract if it's just on a problem list, period. Mm-hmm. Whether there's meat, no meat, there's maybe 20 conditions, mm-hmm. just ballpark. Mm-hmm. So you can abstract them regardless. Anything else has a strict criteria for what you can and cannot validate.
Okay. I got
We're
feedback.
back again.
I know. Woo. I don't know who's in. Let me see.
Wait a minute. Because I muted myself on StreamYard.
Did you? I know you will.
Wait a minute. Oh. Mute.
I can't hear you. You're muted on Clubhouse too. So
Okay, so
now I
I
can hear
muted
you.
myself on StreamYard.
Okay.
So that might be what we need to do because I still see the camera, but I just muted my mic.
Okay.
Okay.
Cool.
So it all comes down to training because you're supposed to be trained before you start a project. But I'm gonna tell you, I worked for a company. They were in Erie, Pennsylvania.
Mhm.
They don't really provide training, and they'll tell you that you have to code what you feel needs to be coded. How does that work? But
Really?
it's supposed to be a criteria. They didn't tell you, no, you can't code this, no, you can't code that. Then if you ask the question, they will say, well, you have to, at the end of the day, you're the one coded, so you have to code what you feel is relevant. That's not how coding works.
No. No. And it's very clear, even in this report, about what the requirements are related to documentation and the guidance that you need for these HCCs. So at a bare minimum, someone should take one of these reports and dissect it if they don't necessarily, well, I guess this goes back to you and their coding manuals.
Right.
If they don't have the information related to the coding manual, or don't have a coding manual to provide for their staff,
Right.
then they could definitely just, take one of these reports and, go to the CMS manuals that clearly outlines and states, this is what justifies this. This is what justifies
Right.
that. It's they give it to you. It's not like it's a mystery.
Exactly.
I tell my students all the time, reading is fundamental. It's right there. It's right there.
And CMS will give you all the information you need.
They will give you everything you need. Hang yourself if you want to.
Yeah. And that's why they do it. Now, my first job at Novaline, they were when it came to training, they were the best I've ever had. Because every project you worked, you got a manual for that project. I mean, a thick manual. There were no gray areas. If you had a question, you flip to that section in the manual. This is what we're going to do. This is how you handle it. And then if not, you escalate it to your supervisor. Then your supervisor will go to the quality manager. They will make a decision. Because, there's always some gray area every now and then. Or there's always documentation that could be but could not be. So they would make a decision. And then they would come out with an email. They would update the manual. And we kept it moving.
Right. Oh no. And these seem, the cases that they had seem to be kind of common diagnoses that you would usually see. But I mean, the cancer thing though, that was scary because there's a whole section about documenting your history of cancer or whether or not cancer exists and what types of documentation you should see to reflect whether it's a current cancer diagnosis or not. The lung cancer, the breast cancer, and the colon cancer that they reviewed, I'm like, those were low hanging fruit.
Right, and those are very common cancers at that, just like you said.
Yes. And then the stroke and so they had the heart attack, stroke, acute heart attack, major depressive disorder. I think that's another one that you see a lot. Embolism, vascular claudication, and then like I said, lung cancer, breast cancer, and colon cancer.
Because when it comes to embolism, especially like acute versus chronic. Now, I remember reading or being told somewhere that when someone is discharged with an embolism, it is considered acute for 6 months.
Mm-hmm.
Then I heard, matter of fact, this year that it's 6 weeks. It's not 6 months.
No, it's a tighter time frame. Usually things and believe it or not, a lot of things where there's time related, particularly to ICD-10, it's usually like a 6 week.
Okay.
It's usually 6 weeks. Wow. Yeah, this is an excellent, I think a great case study for, and this isn't the first one though that they've looked at.
It's
because there was an actual Medicare Advantage plan that that owed money back to. So I don't know if this rolls into, but this shows that the provider's responsibility as well as the plan's responsibility.
And this is why you need to have people in-house like CDI people, like compliance, like you need to have internal auditors. So before the records get sent, they should already be audited. And then also,
and who doesn't do that? That was so in my, that was always one of the things. Like sometimes and it can be a lot. It can be a lot. You know, you can have other projects happening. You know, you're trying to get the bills out the door, but to be hit with a 200, what was it, 280? I think they looked at 280 records. But you just have to band together as a team and take a look, or at the bare minimum, pull a sample of all of those different diagnoses and peek and see, or look for a trend. Is there a certain provider that you see this happen with? Is there, find the trend, and then of course begin that education, because there's nothing you can necessarily do with it. It's right. Done. However, you're prepared. You're prepared for what they may see. You're prepared, even if there's something where you can say, okay, well, yeah, if you look at this, you don't see this, but is there some additional documentation somewhere? I mean, you can prepare yourself for the answers to the audit versus she was just an RHIT.
Right. But there's no, like we said, CMS gives you all the tools. Like they make it very clear how they pick their random samples. Mm-hmm. Like when it comes to risk adjustment, they divide people into groups of 30. Mm-hmm. They have the people who are healthy, people who are kind of sick, and people who are really sick. Mm-hmm. And all of that is determined by the person's risk adjustment factor. Mm-hmm. So it's very easy to internally to even subdivide your members into those groups. Then all you have to do is, there is free software right on CMS's website, RatStat, that you can pick random samples.
Oh, we used to use that all the time.
So it's really no excuse. Then you pick just these random people from those 3 groups, and then you audit. Yep. Now, what it all kind of came down to is UPMC was just, in my opinion, grasping at straws, because if you're trying to say that they didn't review all the information, then there should have been information that they supplied in their response that the government didn't have, but that was not the case. Mm-hmm. And there are times sometimes, because I know when I worked for Novaline, it got to the point they didn't even ask people, they didn't even ask vendors to send records. They would send us to go get the records. Like, I remember traveling, because I used to travel for them, and I would do the reviews and get the records.
Oh, okay.
It started I would just go, they had like 15 of us. We would go all over the country and just go and scan the records ourselves to make sure that we would get in everything. Because, some people, because I have a friend who works in medical records for years, who worked in medical records for years. And she would call and ask me, well, these people are requesting records for HEDIS reviews. What do I send? I said, you send what they asked you. I said, they asked for everything and you send them everything.
That's right.
And I explained to her why they need it. I said, now, they might ask you for a specific measure, but that person could also be in for multiple measures. So you don't know what they're going to ask for. So you send whatever the record is for that year.
And usually sending everything helps you.
Exactly.
Because if you pick and choose something and you don't pick and choose the right thing and you send something, then that ultimately can hurt you in that audit process. So just send it all.
But I've also done audits where I've been reading charts, and you know that this person is sick. You know they've seen more people, but there's no documentation. So you can't. You can only go by what's supplied.
And why are we in a day where there's no documentation? That just floors me.
Because I'm telling you, because it's all about quality.
It's quality, right? Just because and I remember when I worked, this was years and years ago. I worked on a documentation project for the VA, and this is when they were beginning to accept other third-party insurance for veterans. So, veterans usually come with TRICARE, but they if they work somewhere else after serving in the military and they had insurance, then they were thinking at some point, oh, well, we can bill the other insurance if needed. And so they were trying to set themselves up to be able to do that, because if you you would be lucky to find a record of anybody coming in with anything, at that time with the VA. Now they have made leaps and bounds strides in making sure that there is documentation. But before then, it was like, well, you can have a heart surgery and it was $283, and that's how we got it. And I'm like, oh my God, but where's the documentation of the procedure? Where's the documentation of what services that were provided prior to that procedure? And again, at that time, they didn't fall under the same scrutiny as other facilities because they were kind of billing them against themselves. So that was part of our training, was to get them to understand, no, providers, you have to document, you have to write, you have to have a date and time when the person came in, you got to have op report, you got to have clinic visit notes, you have to have all of that. And so it was like, really? And so they would be tracking folks down, and because I know at our VA, at the time, a lot of them were coming from the academic medical center. So the providers weren't necessarily VA providers. They were kind of shared between the two. And you would have your regular physicians, and you would also have residents working as well. And so then you had to try to track these folks down. They would be on schedules and rotations, and they'll be in 1 month and then they wouldn't come back for another 3 months. It was just madhouse. And it was like, so you have to document. And so I'm always floored when you see that folks just don't document. But to your point, it's really about the quality, because sometimes you do have folks that are documenting, and that's the one thing that used to just burn me about EMRs, was the whole copy, cut, and paste. Oh my God. And it was like, my biggest concern with that was, are you really paying attention to the patient? Because every time they come and see you, they're not the same. Every single time. Like, really? Except for, your vitals. I guess you feel like, oh, well, I can get by with just changing my vitals and I'm good. No, not every single time.
And they don't realize how obvious it is.
It's very obvious. Like we actually had in our system, you can go in and like it's similar to what they do in schools with like plagiarism. It's like software where you can hover over and you can just see this is the same, this is the same, this is the same, this is the same. It's like, oh my God. And then we kind of took that a step further and not only compared notes of one provider, but compared notes of multiple providers against each other, where you can see where they're taking from others' documentation to create a note. And it's like, oh my God, please make it stop.
Right.
Make it stop.
But I think that all this comes back to a lot of facilities, they don't really properly train their physicians. In there, it all comes back to documentation, because whether somebody could see 50 specialists, you as their PCP, it is your responsibility to coordinate all that care and document what is being done for your patient when they come to see you. That's all. Like that's the least you can do, because you shouldn't have to, like, a coder should not have to review our, a 500 pages outpatient to determine whether this person is receiving active cancer treatment or not. That should be in the documentation. You should know whether your patient is done with chemotherapy, whether they are continuing, because, like, I mean, I just know cancer runs amok in risk adjustment. Because providers will put down somebody has active cancer in a minute. I mean, and like it's nothing. And a person had their breast removed and went through chemotherapy 8 months ago and is not receiving any treatment. They don't have a history of, they have breast cancer or prostate cancer, and then they'll have it in the plan, follow up with oncology. What does that mean?
Right.
That's not enough to justify a cancer diagnosis.
Right, because where's the documentation of the active treatment for that cancer? Wow. I mean, yeah, I'm with you. I think there should really be some information or knowledge base built around just understanding the purpose of your documentation, because really at the end of the day, you provider, you're telling the story of that patient.
That's right.
Your documentation tells that patient's entire story, and it's telling it to multiple people or multiple channels. So not only are you communicating what's going on with that patient or being the voice of that patient to your peers, so other providers that may be seeing them, but in these cases where you're an enrollee in these managed care organizations, you have like all the other specialists, you have the managed care organization, you have the insurance, folks and quality folks. And as you see at this level, you have the OIG, Department of Justice. In the event that there is some other, this was just an audit, but say there was some sort of somebody has alleged some sort of malpractice or something, then your record needs to speak to what you did to for this patient for whatever condition. So it's like you need to be proactive in your documentation and not proactively trying to make sure you're doing what you need to do in the event of one of these types of events, but proactively understanding and knowing that you're the voice for your patient and speaking, what happens, and I've seen even on the flip side where it's a detriment to a patient, where a provider is documenting something and then the patient is stuck because they can't get insurance, they can't get healthcare, they can't get life insurance, all kinds of stuff because of some documentation that a provider, either had or didn't have. And it's like, then the onus falls on that patient to try to understand, well, why, this is not what's going, and so it's a vicious cycle if it's taken care of up front, if it's taken care of, and hopefully, with this, well, not everybody is doing HCCs or in a managed care, uh, using a managed advantage plan. But hopefully, even if they're not doing that, that some process is put in play where, you know, this happens. You would think that there would be some regular monitoring. I know one of the things that we did was, for on our inpatient side, and then as things were kind of morphing, we would use our pepper reports, and we would kind of determine what's happening with, because it was information for your facility. It was information, you know, grading or comparing, a comparative analysis of where you were compared to other facilities in your region, other facilities in your state, and then other facilities across the country that were similar to you. And so it would give you some information to say, okay, we're an outlier. What's happening here? And at one point in the compliance journey I had, you know, I was instrumental with discussing information with the person who was over health information. And it was like, you know, we had a compliance committee, and she sat on that committee, and part of her report out was, you know, hey, this is the pepper. We see we're an outlier. We need you to do some audits. We need you to do some check in with this. Are we justified to be an outlier? Because sometimes you are, and that's fine. But we just need some information. If we feel justified and we're good, then there's no problem. Business as usual. But if you're not looking at it, or you're not checking to see whether or not, then you're riding blind. And here comes an audit that could have sort of been prevented had you taken the time to pull a couple records and just to see. And I know that seems easy. That sounds like, oh, you know, you got all the time in the world, but really there should be somebody, or maybe some group of folks that are dedicated to doing just that. That helps these organizations be prepared for those services. And I know we have in some of the revenue cycle management side of things, you know, you have like your revenue integrity folks, and maybe that is part of what some of their duties and roles are when, you know, audits come, that they can kind of take a look and say, okay, well, let's jump on this and see. But somewhere, somehow, there should be, like you said, somebody putting their eyes on the information, particularly when they're requesting records to be audited.
I don't believe a lot of these institutions truly and providers, they don't understand true revenue cycle. And because it is so easy to avoid mistakes, but you have to spend money.
Mm-hmm.
And because, for instance, let's take this UPMC situation.
Mm-hmm.
It would have been far easier for them to maybe have employed 2 or 3 more people in their chain to do a checks and balance than to pay $6 million back.
So it wouldn't have cost them $6 million to have 2 or 3 more people, no matter what that salary was.
Exactly. So it's like, I mean,
they could have had a whole team. They could have a whole building with a whole group, 20, 25, 30 folks, and still not got the $6 million.
Like, there's an old saying, an ounce of prevention is worth a pound of cure.
Yes.
And it's like, and the thing is, when by us being in the trenches and seeing the charts every day, we see it, and it's like, why don't you just? I'm trying to help you,
mm-hmm.
but you don't even let me help you because you're not trying to listen.
Damn.
So they have to learn the hard way, and then they want to play the blame game, because you better believe it's some heads rolling at UPMC.
I'm sure, and that's unfortunate, and I think, and I would tell providers all the time, especially, you know, small groups or groups. It's like, it's one thing to get the money, but you better make sure that you can keep the money.
Right.
Because that's where the problem lies. Like, oh, well, we build it and we got it and we're good. No, you better make sure that you did it appropriately. And that's where, to me, compliance comes into play, like understanding the importance of compliance. Um, and then I think even carrying that to a different step, understanding the importance of um, just coding and compliance. So, because you have some departments that don't necessarily have anybody in compliance that has the knowledge of coding rules, coding guidelines, and those type of things. And, they may have other strengths, and that's cool. But I think there should at least be one or two people in your compliance department that kind of shares that. And if you don't, at least be on speed dial with your director or VP or whoever of health information, or over the coding function in your revenue cycle. But even that is sort of, it's good to have, but that's kind of like the fox watching the hen house, but because you need to have an objective person to be able to say, okay, you're in the trenches and you're doing it, so you're going to try to support and justify what you're doing, which is fine. But at least have some objective, like, okay, I see, I know what you're doing, but I need you to check, or let me check. Or let us have somebody else put some eyes on it and validate and verify.
You have to have qualified people,
Mm-hmm.
but you also have to have qualified people who are not afraid to make a decision, who are not afraid to say, this is not right, you're going to get in trouble. And I don't find that. I have found that most places I work, people just want to go along and get along. Oh, would it be okay? Oh, all you have to do is do this. Okay, well, because what people don't understand is when you get audited by the government, they go by the book. Period. There's no questions asked. Okay, this was not documented properly, so you can't get credit for this.
Yeah.
Period. It's like, and there's no back and forth.
None.
Because when it's all said and done, UPMC will cough up that $6.4 million.
Oh yeah. Like, woo. And the thing, there was what was the note in there? There was a note in the report that pretty much said, and you better go check them other records.
Because now they're gonna open up a whole can of worms. Because the government's thinking, well, if we found 6.4 million just doing this, what else can we find?
You about to be a test case. A whole test case. Wow.
But I mean, in just my 7 years, when I start a job, I can tell if it's a well-run ship or not. And what I decided to do, and this is why it takes me a long time to find jobs. I do not work for anybody you cannot be my supervisor if you're not a coder. You cannot. Because it's too much aggravation. Because how am I, if I'm a coder, why is it that I have to explain to my supervisor why this is not correct?
Mm-hmm.
You're supposed to be telling me.
Or helping me, or
Exactly.
passing knowledge down to me, or assisting me,
right.
or
if
at least giving you the resources, even if they're not necessarily a code, have the resource that you can tie into.
You need to be a coder. Because matter of fact, I worked a place, Clarice, my supervisor had a PhD in life sciences. That's nice. I don't begrudge anybody any kind of education, but when I'm telling you,
he said that's nice.
It is. But when I'm telling you that a medical assistant retyped a doctor's note verbatim in a new EMR system and signed them, you should be jumping up and down saying that's not right. She came back and told me, well, They told me that as long as a person has been seen, it's okay. They who?
You sound like me. Who is they? My kids, they used to go, well, they, who is they? Explain they. What is this concept of they? Oh my goodness.
And then I even told, so I ended up meeting with her boss. And I told her boss, I said, I said, what you all need to do, there needs to be somebody, you need to have a coder, you need to have somebody to review all of the discharges for the people who are covered by your health plan.
Mm-hmm.
Because 9 times out of 10, you're going to have an ancillary finding that the hospital's not going to do anything about that will risk adjust.
Mm-hmm.
All the time you find them.
Mm-hmm.
But it is up to the facility, it's up to the care plan to, the care organization to realize, okay, well, on this CAT scan that Mrs. Jones had, they found, abdominal sclerosis of the aorta.
Mm-hmm.
So, or they found an abdominal aneurysm. What are we going to do about it? How are we going to? We have to bring her PCP. We have to make her PCP aware so we can, treat it. You need to have more studies. You need to go to, you need to have a consult. You need to do something so we can manage it, so we can see, so we can at least be monitored. But at the same time, that's a risk adjustable code.
Yes.
But they think all they think about is payroll. Okay, but those fines are far worse than payroll.
Clearly. Clearly. Oh my goodness. That's a lot. I don't understand why they are not putting more importance on those roles that help them in the long run.
Clarice, I'm going to tell you why. Because you have HIM people who do not stand up, who do not tell them. Basically, HIM people truly are the canaries in the coal mine in a facility. They really, really are. And if you don't listen to, because trust me, somebody at UPMC told them. Somebody told them that, but they whoever it was, they dismissed them. I promise you they did, because that's what they do.
Yeah.
I mean, I was blue in the face about at this one particular company, and I was like, you know what, I'm leaving. So,
you had enough.
then I ended up interviewing for another place, and the person who interviewed me used to work for this same organization, and they were like, oh, well, I used to work there too, and it's really, so basically trying to ask me, why did I leave? I said, well, I probably left for the same reason you left. I said, but in the interview, I can't sit around and bash my former employer. I said, I just can't. I said, the game. I said, but I probably left for the same reason you left.
And that's unfortunate. I just, folks don't listen to their people. Let them help you. They're just invested. The people that are doing the work are just as much invested in the organization as your higher ups, as your, they're just, or even more so. And from that perspective, that's how we, we don't have the hands-on care for the patient, but that's how we care for the patient, to make sure that their documentation is correct, to make sure that their story is being told correctly.
Right.
That's how we care.
Then this particular organization, what they did was it was just a whole lot of mess going on. So what they did was, instead of hiring a qualified person, they ended up calling themselves getting because first of all, like, this whole notion that you have to be a nurse and a coder is ridiculous. So they ended, and I'm telling you, I'm coming from a nurse coder, and it's ridiculous. So they got this one person who she had her CPEO. She's an LPN. She got her CDEO. That doesn't make you're not an auditor. That's not an audited credential. But they made her subject matter expert at this organization. And because I had been left, because they hired her as a replacement for me.
But was she an auditor? I mean, she didn't have an auditing credential, but was she an auditor? I mean, had she proven herself to be?
Based on what she was saying, no.
Okay.
Based on her skill set, no.
Okay.
So one of my coworkers, she still stayed there. I mean, and they butt heads for months over silly things, like obvious things. And because Clarice, when it comes down to your monthly QAs, some of those meetings can be contentious.
Right.
Like, wait a minute, this is supposed to be. Then they're like, no, you shouldn't have coded that. Well, right here, you got to have your ducks in a row, your receipts.
Right. It's like the spades table.
And so what happened was, my friends always have a receipt, so they will always have to adjust her QA score. And they were mad about it. And I told her, I said, listen, you need to come up with a plan B. I said, because I'm telling you, these folks are going to fire you because they're not trying to hear it. They literally told her that even when this person was wrong, they were going to back her.
Wow.
So now she's negotiating a setup with the EEOC. But this is what happens. Like they listen to the wrong people. But guess what? At the end of the day, that's you have to write that big check, not me.
True. And you're in a position, again, if you would listen to your people, to help protect you from that, to not have to write, or even when they tell you no one has knocked on the door to audit you, but internally you've noticed some things. And when they come and tell you, hey, we see a pattern here, we see some things, maybe we need to take a look, and then self-disclose. Let them know, hey, we saw some things. We want to let you know. We're not trying to hide nothing. We've seen some things. We're telling you what we saw. We're gonna slide you this check because that check gonna be way lower than a false claims check, where way lower.
Because now that UPMC has exposed themselves, you better believe that the OIG is going to come back and hit them with a CIA. That's coming. So now you got to go through all this. You got to be under the microscope for 5 years. It's not worth it.
And my understanding from having personal knowledge of people who have had to operate under a CIA in a compliance world, it is not pretty at all. At all. At all. So I'm like, oh my God. It's like, how in the world why would they put themselves in the position to be caught up like that?
Because they don't. Well, because
they
you know
don't.
why? I can tell you why. Because they listen to these people. Because to me, one of the biggest companies, one of the biggest red flags, anybody that's associated with Humana, any place I've ever worked, it's a problem. And Humana has this thing that they have this so-called boot camp that they train people to become risk adjustment coders, and they actually call themselves. They take a test. Now it's not through AAPC. They take a test and then they call themselves CPC. Okay.
They do what now?
Yes. They call themselves because that my supervisor, the one who had the PhD in life sciences. Now after I resigned, she had gone through, this boot camp allegedly, and she had taken this test and she was a CPC. But when you go to to AAPC's website, her name ain't nowhere to be found. So they empower these people, and then this particular organization used something called medical scribes. Now, Clarice, you and I both know that medical scribes are nothing but glorified medical transcriptionists. We know it. That's really you have.
But that's what they're supposed to be. They're not supposed to be inserting. They're not supposed. They're supposed. That's their job, is to document what they hear or what they see from that. They're not supposed to insert any of their own.
Yes. Well, guess what? At this company, the coders had to defer to the medical scribes. I was like, this is some horse crap. And my first, I started in September of 2018. By the end of September, because they have these regional scribes, so that was like the head scribe for the region. We were not friends, and it wasn't personal. But I just, I just had to, like low key, blow her up. So I'm auditing this doctor's chart. They're not using any kind of, causal relationship. They're not using any kind of phrases like hypertensive heart disease, hypertensive chronic kidney disease, none of that. So they're not using any of the combination codes. No category I-11, I-12, or I-13. So when I meet with the provider, because in the old EMR system, they were using them, but in this one, they weren't. When I meet with the provider told me herself, well, they told us that we don't have to do that. I said, once again, they who? The scribes. I go, and because my supervisor had come to Philly. So I tell her, I'm like, well, we need to talk to the scribes, because how can they tell them that they can't do that when they're supposed to? That is a coding guideline. Right. And that is also how you get your money in risk adjustment. Right. So we go and talk to the scribe. And so I'm like, well, I just met with the provider. The provider is saying that the scribes, your scribes are telling them that they don't have to use called relationship codes for hypertension. She says, well, you don't. I said, no, you do. I said that is a coding guideline. So this is her response in front of my supervisor. Well, if you want the scribe to code like coders, then we should be paid like coders. So I looked at my supervisor, and she didn't say not a word. So I said to my supervisor, I said, well, see, this right here is your problem. Wow. How can you defer to a scribe who has not 1 ounce of coding knowledge? You're supposed to sit there and write what the doctor says. Period. You're not involved in any discussion whatsoever. But they were knee deep in it. And if this is the direction, and I told my supervisor, I said, listen, you might not be here, I might not be here, because they were in the Midwest. And I told him, I said, I'm going to tell you something. I said, for the most part, CMS really, really keeps an eye on the coast, the East Coast and the West Coast, because that's the most popular. That's where the largest population is. And they go after this money. And I told her, I said, but you all are starting to expand into other areas. When CMS comes calling, they're going to rip y'all an entire new one. Right. Because you wide open. Right. I don't understand. I just, wow. And it's all people have to do, all coders have to do, is stick to what you were taught. Stick to what you know. Don't let anybody tell you that you don't have to follow a guideline, you have to follow a convention. Anybody that tells you that, they don't know what they're talking about, and don't listen. And because, you're subscribing to the ethical coding guidelines. That's you. That's personal, regardless of what I need you to code this way because this is how we've always done it. Or I need you to follow whatever the doctor says because
they're the doctor or, whatever. No, you have an ethical guidance to say, this is what it's supposed to be based on these guidelines. Whether you're an AAPC certified coder or a HEMA certified coder, you have ethical guidance that you must follow.
Period. And a lot of people get, I've seen it. A lot of people get, and then what happens, this is how bad habits develop. And then when you go someplace else, they have to break you out of those bad habits. If they don't just get rid of you. It's just, it's amazing. But all people have to do is follow the rules.
You're right.
Which are very simple.
You're right.
It's very simple. But a lot of these institutions don't have the proper people in place. They don't have the proper people who are heads of HIM departments. They don't have the proper people who are in compliance departments. Like the compliance department is supposed to be the place that settles it all. Once compliance is involved, it's almost like, so let it be written, so let it be done. That's what compliance does. They settle any kind of dispute, and it's supposed to be settled based off of coding guidelines and based off of standards. Period. But they try to save money, and then they get people to try to wear too many hats.
Yeah.
Because I'm very clear, like when I start this job, they don't have, nothing is being done internally. So the CDI is going to be new. But at the same time, now I am a certified auditor. I have auditing experience, but CDI is not auditing.
It's not. That's that's in the beginning stages. That's at the beginning. That's in it's not front office, but it's in the front. Auditing is what comes behind. Now you can audit concurrently or simultaneously, but the documentation is already there for you to audit. So your before or after is based on when you drop the claim. That's what that means. So you can say, hey, you got documentation. Hey, there's some things lacking in that documentation. So CDI is now involved. They're reaching out, sending the queries and doing whatever they need to do to the provider to get them to see or understand or provide the appropriate documentation based on the suggestions, based on the information that they're saying, well, can you take a look at this and weigh in? From there, you can have that concurrent review to say, okay, yeah, we see that everything looks good, and go. You can have that.
Right.
You can have that.
That's what, Clarice, I'm telling you, if you decide to get into risk adjustment with your background, you could just be a consultant and clean up, because people need it. I'm telling you, I've only had one job where it was run correctly. One.
Because it's relatively, I guess, well, it's not as new as, it's been around for a minute. So what is it?
I started doing risk adjustment in 2014. And
that's what I'm thinking. I'm thinking, like, I remember when, this was coming up, because it used to drive me crazy. Now, the one thing that I couldn't understand, me from a provider, professional side of the house, was like, well, now you're about to confuse the doctors and you're about to confuse whatever. But it's really not, because it's really, again, document to your patient, period. And let everybody else figure out, that stuff. Your job provider is to document your patient. And I used to be like, well, this is gonna make them, because they're used to E&M and they're used to making sure, this, that, and the third. And okay. And they document that, but they also need to make sure that they're documenting to the patient's condition as they present that day. It's the same concept. Nothing about that goes away. The only thing is they have a list of chronic conditions, and at some point, you, primary care physician, need to address them. You would think you would do that anyway, right? So it's really not. So when it first came on the scene, I just be like, this is about to be a mess. But then it's like, no, nothing about what the provider needs to do ultimately changes except how they document and their mindset about their documentation. So trying to do some of the things that they would do in documentation needs to go away. And to your point, it's really about their documentation and pulling all that together. Period.
And it's so simple for us because we understand it at a grassroots level.
Right.
But to try to get people to, to higher up to buy into it, it's always a problem, and I cannot understand.
So I remember, so this would be a teaching moment for me in an organization if I was doing this type of work. When I worked in an academic medical center, and this was way back, like when you had the initial, when we were doing teaching physician stuff, you had a classic case of where the documentation didn't support what was going on for teaching physicians. And you use that report and you talk to that report. This is why you need to do blah, blah, blah. See what happened here and see how much money they had to pay back. This is why you do so and so and so. See what happened here. This is what happened. And this is the money you had to pay back. This would be in every education session I would have with both providers and those coders going forward in this organization and in any organization that's providing that, because this tells you right here, this is what they're looking for. This is what they're basing it on. This is what you need to know and have, even though you already got it. They already given it to you from the beginning, but this is further justification of how and why they're coming after you.
Period.
So understand that and adjust appropriately. And that's another thing. If you see some issues, you may want to say, hey, because like I think in one of them, they had, what was it? They did their sample and I think it was for stroke. They did the sample. They had an overpayment of like $63,000. $63,000, 6.9 million. I mean, come on now. Come on now.
Because a lot of people, and I know stroke kind of like, you need a lot of education around stroke. And I know even I have to be careful because you are so tempted to want to code in an outpatient an acute stroke, but you really can't.
Correct.
Because you just have to, and it's the natural instinct. Okay, well, this is what the discharge diagnosis is. But 9 times out of 10, especially with a certain population, they have a late effect.
Mm-hmm.
That late effect is going to be the primary diagnosis.
Mm-hmm.
And I have to make clear when I'm coding, especially in a stroke, you have to it's the natural instinct to do HCC 3.9, but you cannot. It's a knee-jerk reaction, but you really have to kind of pull yourself out of it. And even in home care, one of my charts, like that home care job I had for a couple of weeks, I did it and had the nerve to put the sequela code as the secondary.
Like, what were you doing?
And when my chart was QA, she was like, "No, you can't code acute strokes in home care." And you would think I would know that, but
because we got a problem. We sending folks out here and somebody is having a stroke.
And you're not supposed to leave the hospital with an acute anything. You're not.
Hey Melvin, welcome. We glad it's your favorite show. Welcome. Because the tea is dropped over here. Thank you for checking in. Yeah, that's wow. What we gonna do? We got a lot of work.
I got that report off of LinkedIn, and I was like, I gotta send this to Clarice.
Yes. I'm like, ooh, that was some good stuff. And you can also find them on the OIG website. They generally drop the details of the reports on their website as well. Wow. That's what's up.
Yeah.
That was good. Because it's right here. Everything you need to know. I was on I told you I went to the CPT symposium, and during the second day, that Thursday, they had a lunch and learn, and they had the HCC. There's an HCC book. I think it was the one by I'm about to butcher it, I think, and I don't have my notes in front of me. I think it was the one by Sherry Bernard Poe, I think. But anyway, she was very critical of a lot of some HCC and risk adjustment manuals, and she was like, "Don't let them get you in trouble," And she had like clear screenshots of somebody telling somebody one of them they situations. They said XYZ, and the guidance clearly says do so and so and so. It was like it was blatant. I was like, ooh, she was spilling a lot of tea, and not necessarily to sell her book, because she was clear about that. Like, you don't take it from me. Take it from the guidance. Take it directly from the guidelines. I give you some scenarios and I put some things into play. But if you read the guidelines, the information is right there. And so, she was like, her manual or whatever, her book, because they recently changed the edition. It's a newer edition, but it's to help folks who are interested in testing. But she said it's you don't even if you're not planning for your CRC or any type of risk adjustment certification, it's a great reference guide to have. And I was like, all right. But when she was throwing folks under the bus, and she didn't name anybody in particular, but she was throwing folks under the bus and had them screenshots, I was like, ooh.
Oh, it's crazy.
It was like, oh, people just but to your point, if you have these Medicare Advantage plans training, providing some sort of certification or whatever they're doing, that's scary.
Risk adjustment, period, is scary. And it's scary because they don't have the right people in place. And they don't have the right people training. Because I'm telling you, nothing bothers me more than these people. And it all comes from Humana. Like, they have this in Capstone. I don't know what they're in cahoots, but they really do a lot of provider education in the risk adjustment space. And they are the ones that come up with this suspecting and all that. Suspecting is not a thing. That is not compliant. Nobody, you as a coder, you are not allowed to suspect anything. You are only allowed to code and query. That is it.
Code and query.
If you're not sure, you query. If you're sure you have the proper documentation, you code accordingly. And it's because you have these people who don't know, and you have these facilities who basically, so now you're trying to turn coders into basically CDI people. And you have no idea what CDI is for real. You have no idea how to really, because that's not CDI, period.
No, but, and there's a skill. Just like with auditors, there's a skill to auditing. Now, if that's something that you're interested in, you can turn a coder into an auditor, of course. But it's just a different level that you add on top of your coding skill that you have. Similar with your CDI, it's a different skill set or additional skill set that you add on top of what you already bring to the table with your coding skill. But I think the coding skill needs to be the basis. And well, the other part that kind of scares me, well, not necessarily scares me, but I was kind of shocked. Even when AAPC did that, where they removed like the CPC from, like you can get any certification from the AAPC. You don't have to have your CPC as your base.
Right.
I questioned that a lot. I mean, you would think you want to have a good foundation with the people going into some of these other things. I don't know.
The only one that I can kind of see that, because I don't have my CPC. My first credential ever was my CRC.
Really?
And yep, because that's what I did. I worked in risk adjustment.
Okay.
So I got my CRC first, and I liked it because I didn't have to learn a code set I wasn't using. Because it's only ICD-10-CM. So
or not necessarily CPC, but a coding credential. I'll say that.
Right.
I'll say that. You're right.
Then,
not necessarily CPC, but a coding credential. You're right.
And then afterwards, I got my CCSP.
Okay, you're right. I'll agree with that. A coding credential, not necessarily CPC.
But you have to have, because you have to have a knowledge of ICD-10-CM guidelines.
Period.
That's what drives the majority of healthcare.
Period.
That diagnosis. And because
even if you code on an outpatient basis, even if you code for a physician, you still got to code the diagnosis. And so you still have to have an appreciation for ICD-10. Period.
Exactly. And you have providers who don't know. Like I told you, like I've been working with, a couple of, nurse practitioners who are doing mobile testing. And it's all about information. When you go to the CMS website, they tell you what the acceptable diagnosis codes are that they pay for. It's right there in the document. But if you don't know, you don't know. It's right there. And it's telling you what they're paying for. So you can't have that. Doesn't matter that Mr. Jones has hypertension. You better not put that I-10 in that A box. Or you won't get paid for COVID testing.
Wow.
I see why CMS goes hard, because they give people all the information you need.
I would go hard too. It's like a parent.
Right.
I done told you what you needed to do. Period. All you got to do is follow the instructions. Follow the instructions, and you will have a happy way to go.
But they will run through your organization like a hot knife through butter.
Yeah, I think.
And they don't miss. They do not miss.
Yeah.
Because a lot of people, it took me a while to understand. Like, these medical records get passed around for years. Mm-hmm. And even in CMS, they have like initial review, then they have a secondary review company. They have 2 initial review companies and then 2 secondary review companies. And it's like the checks and balances. Mm-hmm. So it's like, so when they tell you this is not right, it's been through 4 companies that say, no, this is not right. Mm-hmm. Then they go down the hall to OIG and say, go get our money, please.
It's like, it's coming. It's coming. Oh my goodness. I wonder if I can pull this up. Yeah, let me see if I can pull this up. So for those of you who are watching, this is what we're taking a look at, is the report for Medicare Advantage compliance audit of specific diagnosis codes that UPMC, which was the wait a minute, I'm having who is UPMC?
Oh, University of Pittsburgh Medical Center.
I'm thinking Pennsylvania, because I believe that's the one for the teaching physician one. yeah, so some issues that they had. So yeah. Craziness. So if you wanted to deep dive into if you're coding risk adjustment or HCCs, if that's where you're living right now, you may want to take a deep dive into the summary as well as the full report to get a good understanding of what's happening, and hopefully provide some education. If nothing else, provide some education.
Definitely.
Help your people. Help your people.
Yeah. It's not hard. It's not. But you just have to have people who are confident in their skills and abilities and aren't afraid to, to call it out what it is, because that's what we're there to do. Because when it comes to this side of healthcare, like, coders are invaluable. Like, invaluable. Like, they make or break institutions.
They can. That's why it's helpful to, again, not only understand the skill of coding, but understand that there are reasons why. And the reasons why are your guidelines. And they give you clear guidance on what you should and should not do, what you should add and what you should not add, depending on, because there's some different things depending on the site of service that you're providing. And so it's your responsibility as a coder to know that. Where you live, for example, you were in the home health arena. In home health, this is your box. Stay within your box. Do what it tells you to do in that box. If you're an inpatient coder, this is your box. You know what's in your box. Stay within there. If you're a professional or physician coder, this is your box. Risk adjustment. Everybody has their certain boxes. Stay in your box. Understand and know what the rules are and play by those rules in your box. Now, me as a compliance person, I'll tell you can get as close to the edge as that box as you need to. Don't cross over though. Just stay in your box. Stay in your box.
That's right.
Because folks always think compliance, police, they want to tell us no. And I'm like, I'm not gonna tell you no. I'm gonna tell you play in your box. Play in your box. Let's make sure we understand what the rules are in your box and what you can and cannot do within your box.
Period.
But
what happens is you have people who feel as though, I don't have to do it that way.
No.
Go right ahead.
Yeah, go right ahead. And look at you with your 6.9. No.
Exactly. Because believe me, I'm telling you, they've had some pretty fiery meetings at UPMC as a result of this.
I can only imagine.
And there will be some major overhauls of their coding policy moving forward. First of all, they have no choice now. And
compliance as well, because compliance was implicated in here too.
Oh, yeah. Oh, it's I'm telling you, some heads are going to roll, because first of all, you're going to have to, in their CIA, they're going to have a
yeah. If they get a CIA, that whole compliance, yeah. It's you think you got work now, you better take I feel like if you think you're lonely now, but if you think you got work now, wait until that CIA drops, if it drops. And if it doesn't drop, you better be prepared. Put them measures in play. Take heed.
The home health job that I had, they were in the middle. Their CIA expires next year. They had a CIA, and then of course, because they have to disclose it.
Yes.
So of course, they're gonna put their spin on it. Because they basically. We know how CIAs work. We know that it's like the government. They're nice. They're like, you can voluntarily do this, but just know that if you don't, we're going to make you do it. So it's better if you volunteer and say you volunteered. So they went into this whole thing. They had a whole
Voluntold.
yeah, about how they entered into this agreement and they wanted to partner with the with CMS for compliance and blah blah blah. And I'm like, y'all got busted. Just say what it is. You got caught.
Do they not know that there's a whole list? Wait, not only is there a whole list of organizations who have CIAs, the details, you click a button, the details are there. Why? What happened? How long? All that information is public knowledge, public information. There's no secrets there.
Oh, and then the people who don't do proper credentialing and hire these positions who are on exclusion lists.
Who? Oh, so in my limited recent exposure to credentialing, I'm like, my hat's off to the credentialers of the world. Lord Jesus.
They don't get paid enough.
No, it is a special job. That is a special profession, because not only do you have all of the steps and the work that you need to do initially, it's a revolving work, and you have to be on top of it, because they don't, they just doing their little thing. So you do have some providers that may, take it upon themselves to be responsible and say, oh, I think my stuff is coming due. Let me make. Usually it's somebody knocking on their door like, ma'am and sir, it's about time. I need some papers. I need some. And then it's like, it reminds me of to a higher degree, like when my kids was little, and every year, and when they first went to school, it was a huge packet of papers that you had to find, and you had to make sure you had all of this, their immunizations and all of their documentation and all of this stuff signed off, this huge packet every single year, credentialing. You got to make sure, you got to validate, you got to make sure there's insurance, you got to do all of this stuff for these people, and usually it's not just one, it's multiple people. So you got a whole family of folks that you're dealing with that you got to make sure their stuff is right. Now, how do you not check to make sure that those licenses are intact off top is amazing to me. Amazing. Now, we in compliance, we've had we had some situations where everything was good off top, and then somewhere in the process or the time frame that they were practicing, some things popped off. We had to find that. They didn't self-disclose. I was like, you didn't want to just come forward and say, hey, you got XYZ and now your license is suspended or in jeopardy or whatever. But exclusion? Come on. That's the first thing you check. Oh, God. You want them to close your doors. Forget sitting do a fine. You just want your doors closed.
Right. But they know that there are ways that you can slip through the cracks. But credentialing is not easy.
No.
And I had no idea, because I looked into it for like a brief minute, because I'm always trying to do something. But when I looked into it, I'm like, no. Now, maybe, I don't know. If you did it on your own, maybe you could get a little more money, but what organizations are paying for it, I don't think it's worth it.
No. And like I said, I was helping some organizations from as a startup. So they wanted to begin providing the services. And so you're just making sure that they're credentialed appropriately. And you're checking all of this stuff. And so it's just one or two that oh Lord, I can only imagine.
And then how do these hospitals do it when they have all like these huge hospitals?
Exactly.
They have all these residents and interns.
And it's a constant. I mean, it's like every day it's probably somebody that's up for, review. You got to go in and check. And then that management of that's huge. So I'm sure there's, credentialing software, at least there better be, or, something that manages or helps them manage and gives them ticklers to be like, we 6 months out, make sure you get in touch with Dr. So-and-so or nurse so-and-so or whoever because that's a lot. That was a lot. And you're right. They don't pay them enough money. The providers need to be putting together a whole fund for them. Even if the organization doesn't pay them, they need to be tipping your credentialing staff.
I mean, just being a nurse is, when it comes to renewals, it's a whole lot. But that's just on the state level. But when you are a provider, you have to look at the state level and the federal level.
Right.
Got to do all kinds of checks.
Right. Like, wow. Ooh, this is good.
Oh, have you been to any of Ask the Billers webinars?
I did. I joined her webinar last month.
Okay.
I joined her webinar last month. And she dropped some gems over there.
She does.
She dropped some gems. Shout out to Ask the Biller. So anybody that's into billing, she's bringing the knowledge.
She really is.
She's bringing the knowledge. And I know she talked about, the differences between coders and builders, because they used to just get me, especially some of these programs that are combining them together. Like, it just makes me question, do you know what they do? Do you know the differences between the two? Do you, people be like, oh yeah, I got a coding and billing certificate. What does that mean?
Yeah. Thank you.
What does that mean? So I've heard I got a coding and billing diploma or a coding or billing it's a diploma. It was something, and I was like, oh my God, what does that mean? Coding and billing degree. I've heard that too.
And here's the sad part though. They really think that really means something. They really think that can get them a job, because one of my neighbors, couple things, maybe 2 Thanksgivings ago, 2 or 3, her neighbor had come over, and she told her, my cousin told her neighbor that I was, I worked in coding. So she was all in, and she was saying that she was in this program and she was almost finished. And so I'm like, oh, well, good for you. So she was like, life happened. So she started and stopped. So she said, well, I'm going to need some books, before I could take my exam. So I said, well, what year? I said, I had some old, because I buy books all the time. So I said, well, I have some you could probably use. So I said, well, what exam are you trying to take? I said, is it the AAPC? So she was like, she named some kind of organization. I'm like, this don't. So I said, so when are you going to take her AAPC? So she was like, well, no, I have to take this exam through my school. It's through this organization. So she took it and she passed, because she texted me and told me she passed. But guess what? She's not working, because these jobs require either AAPC or AHIMA credentials. I think it is a shame that they take these people's money. And it's
predatory.
Not cheap. Predatory. Right. These schools are not cheap. They're not doing this for no $6.99. They're like, these schools are charging like 9, 10 up thousands. And then you go through all that and you still cannot get a job. And the thing is, they don't know enough about either one. They're like a jack of all trades, a master of none. They don't master billing or master coding. So it's like you're still stuck.
it's like, oh my God. It's shameful. It really is. Um, I don't know how those things are regulated. I don't know how they get that off. Really, I don't. Um, I was an organization had approached me and asked me could I come help, teach for them. Now I didn't know the behind the scenes. I didn't know anything. We have several of these coding billing programs, schools. Well, they're not just medical, but they have like medical and other career technical kind of programs that they're providing. I think, well, I don't know if they were trying to put together like a whole medical assistant / coder / whatever. But they just wanted me to provide some information and expertise on, coding. And I'm like, okay, so I'm coming coding, your coding program. I'm like, so show me your curriculum, tell me where you are. And so, this is what we needed, some ICD. I'm dating myself, this ICD-9, so it's way back. We got some ICD-9, here's CPT. I don't think they even talk HCC. So I was like, so you're missing one. let's talk about that. You're missing one. So I was like, okay, well, let me pull together some things, whatever. And so I go to the classroom and there are like 2 people in the class. After a couple weeks, I'm like, because I'm doing regular activities, to me, it's what you teach it and you do it. You teach it and you do it. You don't master it unless you're doing it. So I'm teaching and then we work on the problems. I'm teaching and we work on the problems. They could never, they seem to comprehend. They could recite different things. They could tell me whatever, or tell me what I said, what have you. But when we sat down to do, we would have a problem. There was a disconnect. They could not read. I was like, excuse me? So they were like, oh, well, she comes to your class in the day, or they come to your class in the day, but they're taking like a GED program at night. I'm like, excuse me? Like, do you not understand what coding and billing entails? They can't read. Oh, and you're taking their money? They can't read. They cannot be successful in this program. It. Yeah, they may get to wherever they get their GED, but are they really at the level where they can comprehend any of this? So you just taking their money, because who's going? It was painful. I was like, I can't do this. They can't, because I'm not going. I mean, and they weren't brand new. This wasn't their first class. They had been in this program for a minute. So who passing these people along, giving them, and I'm all, me, I'm motivation down to the what? Let's help you. Let's come on. Let's do it. We can do it. But you don't take somebody's money if ma'am and sir, no.
That happens so often.
I'm like, oh, it was just sad. It just saddened my heart. And so to me, that's where you get the naysayers in our profession. Some of them, that's where you get a lot of, oh, I took the coding billing and I'm so-and-so and I never, oh my God, well, where did you go? Well, like, to your point, what exam did you take? What certification? What was it, an accredited program? Was it, and especially if you're going through a school. If you're going through a school institution, come on now. You check the credentials if you're going through a school. Now, if you're going through a coding training or those type of things, check the credentials of the person that's teaching you. Check the instructor credentials.
You need to do that even in an accredited program.
Well, that's it.
Let me tell you. Because that's the situation I just went through this past summer. I mean, I was a tutor at a very accredited program. I mean, the matter of fact, the director of the program, the head of the the HIM department program, the program chair, is the state AHIMA chapter president.
Wow.
And she has an instructor there who has a master's but does not have one coding credential and is teaching ICD-10, CM, and PCS intro and advanced.
Why do they do that? I mean, there's so many other things that person could teach. You know, to me, that's a specialty, and so you would want to make sure you have specialists teaching that. Wow, I don't know.
Here's the
And
thing.
maybe it's a lack of teacher. Maybe there's a teacher shortage as well. I don't know.
But guess what? But if that's the case, you don't shortchange your students.
You don't, and you let them know, or you find. Oh.
But if that's the case, you teach the class. You're
Well,
the
yeah.
head.
If she has the credentials to do it, why not? Well, you know, once you get in some folks, once they evolve, they have evolved. They don't want to come back down and do that part.
And I'm telling you, like those people are just like the other, are just like the people you just talked about in these
Predatory, yeah.
Because I told them, like, because not many of them came to me for tutoring, but the ones who did come to me for tutoring, that's how I realized they weren't teaching. He wasn't teaching anything. Like, they didn't even know that the coding guidelines were in the front of their coding book. I'm like, how can you code when you don't even? I'm like, no wonder you don't have a clue. So then I write this. Did I tell you this story? Oh my God. So Clarice, so this one woman, I tutored her from January of last year until January of 2021 to August of 2021. She started with me in medical terminology. Then went to the intro class in coding. And she wasn't really learning anything because most of them don't learn anything because he's not qualified to teach them anything. They don't know. He passes them along, period, but they know nothing. They know no guidelines, no causal relationships, no nothing. So she didn't want to take an advanced class until she was really motivated. So I said, listen, tutoring is free. Take advantage of it. I said, if you want to review your introductory class, that's what I'm here for. So I taught her coding. We didn't review any of their material. I got my own stuff. So I taught her every week from then until July, because she started it because they have 7-week sessions. So she took the advanced class in July, started in July. She was doing so well that in August, Mr. Man reaches out to me and basically is trying to insinuate that she was cheating.
Oh my goodness.
So it got ugly. And so I said to him, because he wanted to know what exactly were we working on. So he was like, well, how, because I said something. I said, first of all, it is not, I said, you're an instructor. You're not my supervisor. So if you have a question about anything that I'm teaching or helping a student with, you go to my supervisor. You have no business contacting me, number one. Number two, if you're trying to say that she's cheating, then just come out and say it. I said, and number three, I don't know. I said, you must not know about me. I said, number three, I have been a nurse for 28 years. I have 9 coding credentials and 7 years HIM experience. She don't have to cheat because she's taught by the best in Pennsylvania. I said, now, I don't know if you're trying to say she's sharing her answer. I don't know about that. Maybe she is. But I'm telling you, she ain't cheating.
And you would think you would want to help your students become successful. That's a reflection on you and your.
But if you know you didn't do it, how would you don't feel good about that?
Exactly.
So, but the thing was, I figured out that he wasn't a coder. I could just tell because from the time I started, he was resistant. I could like, I'm like, because first of all, because it was like I didn't have access to this. I didn't have access to the books. I didn't have access to the course material. I'm a tutor. I'm an employee of the school just like you are, but I don't have. He never got around to giving me access to his courses. So I told my supervisor, but first of all, I said, I'm a coder. I said, I know how to code. It doesn't matter what class he teaches. I know the guideline. I said, I don't even have to have it. I said, but the bottom line is, if I'm supposed to help the students, then I need to be able. And I told her the only reason why I need it is because some of them they mispronounce words. So I need to read it for myself so I can help them. That's the only reason why. Not that I needed to do the job. If they were better, if they could recite it a whole lot better, I wouldn't even need it. You know how many coding questions I've answered in 7 years? There ain't nothing to come up with that can stop me, not him. So, long story short, I ended up writing a 4-page resignation letter.
Wait, not a 4-page letter.
And when I tell you, Clarice Warner, I wore them out from Genesis to Revelation. All professional.
Oh, I'm sure.
And I told him, I said, the sad part is you are destroying people's lives. I said, these are mothers, these are women who are trying to change their lives to upgrade themselves and their family.
That's right.
And you are setting them up. You are taking their money, setting them up for absolute failure.
That's right.
All they're going to do is end up with a piece of paper from your school that will still render them even more behind that evolve. And now they got to pay back a whole bunch of student loans to a school who did not provide them with anything.
Yep.
They were sick of me.
Yep.
But
and
it's
there
the
should
truth.
be some way to prove that. Like, I didn't get anything. I shouldn't be responsible to have to pay this money back because they didn't give me what I got.
But see, here's the thing though. See, this is what academia has done a job on people. When you pay your money to a school, the school works for you, not the other way around.
Mm-hmm.
And I told them, because some of the students, because once they found out I was leaving, well, actually they ended up firing me technically. So, which was fine, go ahead, live your life. So, some of them reached out to me, and I'm like, listen, it is not up. I said, I can't fight this for you. I said, if you want help, I can. I said, listen, if you listen to me, you can get all your money back and get a free education if you play your cards right. But they are so fearful of ruffling anybody's feathers because they feel as though, well, I still need to take these classes. I still need to go to the school, and they're afraid that there's going to be some kind of ramification if they complain. And these are adults. So I told them, I said, listen, I can't help you. I said, but all I can tell you is what was done to you was not right. But you don't want to fight for it. I can't fight for it. I'm not going to fight for you.
No.
I said, because I don't need them for anything. I was an asset to them. They didn't do anything for me, for real. I said, so that's up to you.
And that's telling too, because even in the profession, I mean, there will be times where you would have to speak up for yourself. You will have to say, you stand on what you on your work, on the quality and integrity of your work. And so, yeah.
But people, there's so many landmines to coding, and it really shouldn't be. Every program should be putting out quality students, and they don't, because their intention is not education. Their intention is money. And then these people are left holding the bag. I mean, I've tutored people who have paid thousands of dollars for online courses, and they can't tell you that heart failure is linked to hypertension unless it's documented by the provider that's something else. That's basic, but they can't tell you.
I think there's a lot of programs. Well, I can only speak for mine, but I think there are lots of programs that do not. Even to Terry's point, because she was like, coding is hard. I think there's a lot of programs that don't give you the information to support why you're doing what you're doing. They're not teaching you the guidance. They're not teaching you, because if you have that, the rest of it, I mean, it's easy to, and I think people are taught, oh, all you got to do is have a diagnostic statement and go look that up, and voila, you're coding. No, it is so much more than just that. And I think that's where the disconnect is for some programs. And, you know, yeah.
And I think because what I have found, like in my honest opinion, because a lot of these colleges would use a HEMA curriculum. Mm-hmm. And to me, I find HEMA's curriculum to be, there needs to be more work in the middle area. And I think it's either too basic or it's too hard. And you can't go from these chapter questions where, you know, if you're on, you know, the cardiovascular system, you only answer questions that the answer is anything cardiovascular related. There's no comorbidities until you get to what they call like the cases. Then the cases are very hard. The cases require a different approach where you have to teach people from the beginning how to break down a scenario. So you give them, they should be given scenarios from the beginning.
Yes.
And that way you're already used to breaking down, because I always teach, and all of my students, I teach them, number one, the first thing you want to determine is where is the care being given? Is it inpatient or outpatient?
Yes.
Why is the person being seen? What has brought them into this particular encounter?
Yep.
What other comorbidities do they have? What is their diagnosis? Then once you have those people, then that's when you put it all together. That's when you use the coded guidelines, and that's when you determine, okay, well, if it's outpatient and they have rule out, I can't code that, but I can code the symptoms.
Yep.
That should be instilled from day one.
Yep.
And that's not what happens. And then when they go to take these exams are timed, number one, so that's stressful. And then you're never going to have a question where, so and so is what's the code for diabetic retinopathy? Not on the coding exam. No. They're not asking that. They're not even gonna link them together. They're gonna say so and so is a type 2 diabetic. You know, they have CAD of the native coronary arteries, hypercholesterolemia, and they have retinopathy.
Yep.
You have to know that you have to link the diabetes and the retinopathy together.
Yep. In
addition to the other comorbidities.
Yep. And to your point, it's all about that guideline training. Yep. Wow. I don't know. And another one of the tips that I always tell people when they always ask, or, you know, I was recently, I think I was in the AAPC Facebook group recently, and a lady had reached out and posted a question. You know, she was like, I just want to vent. She had taken her exam. She had just taken her exam like that Saturday. And so she wasn't sure whether or not she had passed or not. But she felt like she didn't, because she had gotten to, the proctor said, you have 30 minutes. And she had so many questions left to go. And, you know, she just felt like it was just the time. And so, and my number one test taking strategy is to practice under time. Practice your questions under time, especially if you're taking the AAPC. It's like a 2-minute per question to practice, so you get a feel for that time constraint. And then, you know, And I know a lot of people, and I don't question one way or the other how people do things, because people do things differently and people are different. But I know a lot of instructors or a lot of programs, they'll tell their students, do all the easy ones and save the hard ones for at the end. And I know as a proctor, I proctored for years AAPC exams. And, there's the first half of that test is quiet, it's focused, it's what have you. After that second half, and we always would tell people they were halfway, you had an hour remaining, you had 30 minutes, you had 50. So at that point, I feel like as the proctor, I'm talking a lot. And so I'm adding additional stress to you because now it's getting closer, So if you got huge scenarios, or you're in unfamiliar territory or territories where you were not completely strong at the beginning, mentally you're gonna spaz out. And so to me, that does a disservice. I'm the type of person, and it's just me, but this is what I share with my students. I want the hard stuff early because I want to breeze through the rest of my day. So when I get up and I'm ready to I'm tackling whatever is difficult or whatever I had challenges with or whatever, because to me, I feel like I have a little more time. I don't. You still got the same amount of time. It just feels like I do. I have more time, because if I get to the stuff that's easy, it's only going to take me a few seconds to, this is this, and I can get those done. And so that I always do that. But number one rule is take the practice exams under time. Practice, but take them under time. So because the stress, I remember I felt like I needed a massage after my exam. It was like, because you just felt this whole weight while you were taking the exam. Like, oh my God. Yeah. So
it's a whole science to test taking period.
And I teach that in my class. I have a whole test taking strategy component. Like, you got to understand. So it's all these components. You need to know, the art or science of coding. You need to understand the guidance behind it, and you need to know how to take a multiple choice exam.
And
under time.
Right. And AHEMA, I don't know what AHEMA's got going on, but do you know now you can't even mark questions and come back and review them later?
Really?
You have to go straight through. You cannot come back to a question. I think that is ridiculous.
With their the way they do it electronically? Wow. Because you used to have this time was set aside for this section. So whatever you did within that section, that was, wow. Now, once you moved on to the other section for the new time, you didn't have that luxury.
Oh, no. Now, because I know when I did mine, it was all one time. But you just had to finish that first section, then you went to the next one. You didn't get a new clock. It's all in the same time. But at least then you could mark questions for review and come back. So you had to finish the first section before you went to the case.
Right.
But now you can't even mark them for review. You have to go straight through, which I think is unfair.
Oh, that's rough. That's rough. Because you're going to eat that clock, you're going to eat that clock.
Yeah. Because sometimes now I'm going to honestly, I'll be honest. I don't think having taken both, and taking both tests with both organizations, I found that the AAPC questions were a little more difficult. I think they require, and some of their scenarios were long.
Mm-hmm.
But with AHEMA, I didn't find their first section, because it's all like multiple choice, because they reserve all their cases for the end.
Mm-hmm.
Like there's a whole separate section for cases.
Mm-hmm.
So their their questions weren't as detailed. Mm-hmm. But sometimes when you're in a test taking mode, sometimes you might draw a blank, and another question 3 or 4 down will trigger you. Oh, okay. Well, now I know how to answer this one,
mm-hmm.
but you can't even go back, which I think is is unfair. But what I always tell people whenever they take an AAPC exam, because that's what I learned, is to schedule both of your attempts at the same time. And just give yourself like 3 to 4 weeks between, because it's going to take a week before you get your results anyway.
Right.
And then at least that way, if you schedule it for a month later, you still have 3 weeks to study while it's still kind of fresh, as opposed to you got to wait, because some of those places, like, you got to travel. I've never taken. I have 3 AAPC potentials, and each test I took it at a different location.
Really?
Because what you might not, that the chapter that's close to you might not, they might only have tests twice a year.
Mm.
So you got to find what's available. Luckily, here in Philadelphia, it's not that hard to find in the area, but
that's good, and that makes you accountable. It keeps you accountable for
right.
Let me get on my study and let me stay in this vein so that I can be successul with my certification. Right. All right, sir. We spilled a lot of tea today.
Yeah. I really hope that that the people who watch Zoom and come into your room, I hope they realize how much value you're really giving.
You as well. Because the tea you drop.
You are the captain of this ship. This is your baby. And you have created a space where tea can be spilled, okay?
And I try. Like, if the real is right here. Like, and if you have questions, feel free. You can always ask the questions. You can put questions in the chat. We'll, pull your questions. If you're on Clubhouse, you can always, ping us like, hey, say your piece. I do pay attention to see who's in the room, to voice your question or concern or what have you. And that way, it's a constant dialogue. Now, I know for the Clubhouse folks, it was my bad. I thought I had scheduled, so I need to, because they won't let you schedule. You only can schedule so many in advance. And so my mind says, schedule the month and we'll be done. And I guess this is the last one of the month. So I'm always one off, and will be the one off. So that was my bad. I need to make sure my stuff is scheduled out. So I'll make sure I'll do better. That was on me.
Look, it was still a value, nevertheless.
It was still a value, because then they have the replay. They can always come back and check out the YouTube, the replay. So cool. Well, I hope you have a wonderful rest of the week.
Thank you.
We'll be out here looking and scouting for different things to bring to our Saturday morning tea. Again, thank you all for watching. Make sure that you like and subscribe to this video if you found value. Go out and check out the Coding Nurse. The Coding Nurse also has a YouTube channel, so feel free to go and check out the material. He dropped some additional tea over there on his channel. I've watched several of his videos, and he's bringing it, particularly for those of you in the nursing field that are looking for another pathway. He gives you the guidebook. This is what you need to do. You bringing this knowledge. This is how you can up your game and take it to another level. So definitely go out, check him out. Be a subscriber to his channel. Help him get the word out. Be a subscriber to this channel. Help us get the word out. The more people that we can provide this information to, the better. We're all better for it, if you will.
That's right.
Yes, definitely. So again, thank you all for being here. I'm so glad you finally came into the room. Look at you. I'm so yay. Yeah. I'm glad we got the audio together.
Yeah. Now I know what to do.
We know what to do. We didn't have a practice, but hey, we pulled it all together, so it's all good. So yes. So thank you for coming here again. Have a great rest of your weekend, and we'll definitely touch base.
Okay.
All right. Bye, everybody.
Bye-bye.